Hi, my name is Professor Len Calabrese from the Cleveland Clinic, and I am delighted to present highlights of the ACR Convergence 2020 on behalf of the Cytokine Signaling Forum. ACR kicked off yesterday with the opening session, Rheumatology Strengths, Science, and Resilience. It was chaired by our president, Dr. Ellen Gravelisi. The session featured Editor-in-Chief of the New England Journal, Eric Rubin. If you haven't seen it already, we recommend watching his presentation, COVID-19, the Convergence of Infection and Inflammation. Thursday represented only the very tip of the iceberg, with a wealth of data being presented over the coming days. The CSF have chosen a selection of highlights with the aim of sharing the most notable abstracts in cytokine signaling science with you. I'll now review Friday's highlights. Let's turn to spondyloarthritis. First, the poster I'd like to turn to is presented by Professor Atul Deodar, looking at the effects of Uppa on pain in patients with active axial SpA and inadequate response to nonsteroidal and anti-inflammatory drugs. So as we know, pain is a debilitating symptom in AS and negatively impacts on patients' lives. Uppa 15 showed efficacy versus placebo in the phase 2-3 select axis 1 studies in AS. And this analysis evaluates the efficacy of Uppa on multiple pain assessments. So in this study, there were a number of different questionnaires applied. And it showed that a significantly higher proportion of patients receiving Uppa versus placebo achieved reductions in all patient global activities assessments of pain as early as week 2. Sustained to week 14, except for the PGA, which was significant at week 4 and sustained thereafter. Mean changes from baseline in the patient's global assessment, the BASDI question 2, total back pain, nocturnal back pain, which is important in patients with SpA. All of these were significantly greater for Uppa versus placebo at all time points to week 14. The BASDI question 3 was significant at week 8 and week 14. The effect of Uppa on pain reduction was sustained through week 64, and placebo patients who switched to Uppa generally reached the same levels of pain reduction of those originally randomized to active drug. So we would conclude, and I think this is reassuring, that a greater proportion of patients treated with Uppa versus placebo achieved rapid, significant, and meaningful reductions in pain, which were sustained over time. Second poster is from Professor Mark Genovese and colleagues, and that was a phase 3 analysis of Uppa in patients with PSA with inadequate response to biologic DMARDs. So Uppa was approved for RA, as you know, and is advanced in its studies of PSA. This study was designed to assess the efficacy of either 15 or 30 in patients with PSA with prior inadequate response or intolerance to one or more biologic DMARDs. So at week 12, a significantly greater proportion of patients receiving Uppa 15 or 30 versus placebo achieved ACR 20, and the numbers are impressive. 56 plus, 63 plus versus 24 plus %, as well as ACR 50 and 70. So a large differential between placebo and active drug. Statistically significant improvements were also observed in both Uppa arms versus placebo in all multiplicity controlled secondary endpoints, including HAQ-DI, the physical component of the SF-36, the FACIT fatigue, and the self-assessment of psoriasis symptoms, a patient-reported index. Frequency of treatment emergent adverse events was comparable in the placebo and Uppa 15 arms, and higher in the 30, and that's a theme that we saw through the RA trial. So a greater percentage of patients receiving Uppa than placebo achieved MDA at ACR 50 and 70, and no new safety signals were identified to these observed in RA. I take away from this is a very auspicious trial for psoriatic arthritis for this drug. It'll be interesting to see how the 15 and 30 compare, because that was, we know from tofacitinib in psoriasis space that took a higher dose to control skin but not joints. So we'll see as we move down the line. Thank you for tuning in to the CSF Daily Highlights. We hope it's been informative. Look out for tomorrow's edition, available on our website, cytokinesignaling.com, and on YouTube, Cytokine Signaling Forum. The CSF is providing extensive coverage of 2020 ACR convergence on the CSF website. You can find our full abstract search and recommendations in our highlights brochure, which is available now. Look out for presentations from authors of notable papers, as well as our highlights from ACR course, where we'll go into more detail on some of the most notable abstracts presented. Thank you.